please take it over.
Hi, folks. Thanks for joining today's webinar. My name is Elise Colgrant, the co-chair of the New York HIMSS Programming Committee. I'm really excited to bring this webinar to you all today. It's very timely. Matt Bishop, who's the CEO of Open City Labs, came to HIMSS and said, hey, it's very timely that we put on this webinar talking about the 1115 waiver, talking about how social networks, social care networks are going to get involved and what that means for the behavioral health community, what that means for the physical health community. And one of the things that we've really been doing at New York HIMSS is reaching out to your unstandard healthcare practices. That means reaching out and providing platform opportunities for social care networks, for community-based organizations, for outpatient services, to speak on the initiatives that we're working on and how we can better integrate our healthcare services to really accentuate whole person care. So with that being said, I'm going to introduce Matt Bishop. We sat on various HIMSS committees together. Right now, we're both on the National HIMSS Committee for Social Determinants of Health. And with that, Matt, please take it away.
Thanks. It's really a pleasure to be here. As Elise said, I'm Matt Bishop, CEO of Open City Labs, a member of the STOH committee. Open City Labs, we connect patients to the clinical social services and government benefits that improve health and well-being, and providers to the tools that can connect clinical care with social care and government programs. I'm involved in many different standards organizations. Not going to go through the full alphabet soup, but in addition to the Gravity Project and the CMS National Directory, I'm involved with co-authoring the 360X Social Determinants of Health Closed Loop Referrals standard with Epic, and I'm very interested in advancing health equity and advancing the types of interoperability that will enable these healthcare and social care providers to address the health equity and the health and social needs of patients. I'm going to just go from left to right on the screen. Zach Hennessy, he's the Executive Vice President and Chief Strategy Officer of Public Health Solutions. Would you like to introduce yourself, Zach?
Good afternoon, everyone. I'm thrilled to be here. I'm Zach Hennessy. Looking forward to the conversation.
Great. Kathy Miller, do you want to, she's the Chief Operating Officer of Bronx Rio. Do you want to say a few words about your background, Kathy?
Just a little bit, so you have a little context on me and my role here. I started out in hospital administration and planning in the poorest neighborhoods of New York City, and then spent 10 years in public health, and have been working in the health information exchange world for the last 10 years, really trying to pull together ways to give the provider and CBO communities the data that they need about their patients and clients in a user-friendly and accessible way.
Great. Pamela is the President and CEO of Coordinate Behavioral Care. Would you like to introduce yourself, Pamela?
Sure. Good afternoon, everyone. I feel like we should go back to Zach and give him a minute to say more than his name. But
I didn't realize we were at that stage yet. I apologize. You want me to go now?
Yeah, no, go ahead. Of course, Zach.
I'm currently Executive Vice President and Chief Strategy Officer at Public Health Solutions, but I have a 20-year career building trustworthy and reliable spaces for historically marginalized people to receive care, whether that has been at a community-based organization, nonprofit where I started, large health systems where I have worked over the years, a small safety net hospital, as well as in my current role at Public Health Solutions, New York's largest public health nonprofit.
All right, so now I have big shoes to follow after you said all of that. So good afternoon, everyone. I'm Pam Mattel. I'm the CEO at CBC, which is a large behavioral health IPA. I have been in the nonprofit world for over 35 years and have been really focused on integrating behavioral health, primary care, housing, and social care needs across complex organizations and in the broader environment. So being invited to join this conversation is really exciting. So thank you for that.
And Mark Ropiecki is the Executive Director of Care Compass Network. He joins us from upstate New York. Mark, do you want to introduce yourself?
Yep. Thanks, Matt. Great to be here this afternoon with everyone. My name is Mark Ropiecki. I've been with Care Compass Network since 2015, and prior to that, I was with Deloitte & Touche's healthcare advisory practice and really helped solve some complex system issues across predominantly the East Coast of the U.S. And since moving to Care Compass Network and migrating my way upstate, have helped to solve some of the challenges of regional collaboration. It really started around the original DSRIP program, where we focused a lot on how we can organize and integrate CBO networks with the clinical sector. And we're encouraged and excited to see this new waiver and see how that work can be built on.
Well, thank you to each of you for joining this panel. We really have 4 thought leaders, and the reason they were selected is because they have experience running social care networks of different types, not necessarily in the exact same type way of the context of this new waiver, but we wanted to get their expertise and talk about how they expect the waiver to unfold and the potential impacts. So I'm going to jump into kind of just, we've already introduced the speakers. I'm going to give an overview of the waiver, talking about what types of patients are covered, what services are part of the Level 2 enhanced services. We'll spend most of the time talking about the role of the social care networks, and Kathy will speak to the role of the RIOs and her own health information exchange within the broader system. And then I will speak to a few of the lesser known provisions to the waiver. Each speaker will then have a chance to introduce their organization and provide a little bit more context about their organization before we open it up to a moderated panel discussion and Q&A from the audience. So the overall goals of the waiver are to advance health equity and reduce disparities while supporting the delivery of health-related social needs, including the plan is to reimburse up to just over $3 billion in social services. In terms of who is going to be eligible for these services, Level 1 patients, that would be all Medicaid patients, will be eligible for being assessed for the health-related social needs and referral to existing state, federal, and local programs. And these are programs that are separate. They could be programs like SNAP or WIC that are not part of the enhanced services. But taking a step back, the role, we're primarily going to be talking about the role of the social care networks, right, and the health-related social needs. That's the primary the focus of this this waiver. But I wanted to just make sure that I was clear that there is a whole lot of other programs that are involved with the waiver that we're not covering. And I encourage you to go to the New York State Department of Health website, and they have a whole webinar on these. I also want to thank the New York State Department of Health. Some of these slides I've actually using content from slides that they've presented because I wanted to be accurate. So what are these social care networks? Well, they are currently, we're undergoing a process. There's a social care networks RFA that was released on January 16th, and the applications are due on March 27th. And there will be anywhere from up to 13 social care networks selected across the state. They will serve as the organization that will provide a governing body, bringing in leadership and organizations that reflect the needs of their region. They will be contracting with the managed care organizations and with bringing together a network of community-based organizations that will get ultimately reimbursed for these social services. They will process these claims and pay the CBOs for those services. And all of this will be made possible through this healthcare, some kind of IT platform or platforms that will enable assessment of social needs, data sharing, and closed loop referrals that tie into the services that are going to be reimbursed. And they will also manage the network capacity of those services, collaborating across the regional partnerships. Talking about kind of who will qualify for these enhanced services, Medicaid high utilizers, individuals enrolled in a New York State designated health home. Pamela is the executive director of CVC, which is the largest health home in downstate New York. So we can talk later about how she sees these programs interacting and aligning with one another. Individuals with substance use disorder or mental illness, intellectual and developmental disabilities, individuals who are homeless, pregnant persons, and up to 12 months postpartum, and people who have had criminal justice involvement and have serious chronic conditions, juvenile justice, who are involved with foster care system, children under the age of 6, and then children under the age of 18 with one or more chronic conditions. So I'm not going to go through all of what services are covered, but all patients will be eligible for the screening of the health-related social needs with the Accountable Health Communities screening tool. There will be basic case management, outreach, and referral and linkages to these other programs and case management, and there will be a more enhanced case management for the patients that are eligible for enhanced services. And these services here are in housing, supports, nutrition, and transportation are the services that will be covered under the enhanced services. Kathy, I think this one is going to go to you.
Okay. Thanks, Matt. So as I think most of you who've worked in this arena understand, the ability to share the data about people's screening identified needs, their further assessed needs by the SCNs, the referrals that are going to get made, there has to be a really robust data infrastructure behind all of that data sharing. And for those of you who've worked with any of the New York State RIOs or qualified entities, as we're also called, QEs, you know that we have a statewide network in place. It's been somewhat limited to sharing historical data across QEs and alerts about current inpatient and ED notifications. But we're expanding that now and have been working on this for well over a year to have a statewide or shiny data lake for public health and Medicaid support that will be the data backbone of collecting all the screening data and referral data and moving it around across SCNs, back and forth to CBOs and healthcare providers if that's needed as part of the data flow, which is very much still an evolving thing. And also will be part of the infrastructure that reports data up to Medicaid. So the shiny leadership has committed to Medicaid that we can do this, and we are all thoroughly invested on this. All 6 of the QEs and NICE spend many, many hours a week working on these initiatives. There's not going to be any wrong door for screening to come into this system. It can come from a CBO, from a referral management system, from a hospital, another healthcare provider, an SCN. But all of the screeners are going to get normalized, data validated, and sent to this shiny data lake where they'll be linked so that all the screenings done on a particular individual are linked together. Hopefully this will help all the folks in the delivery system part of this avoid rescreening unless it's absolutely necessary. So all the screenings will come into the data lake, and then there'll be systems for getting them back out so that the QEs will probably get a nightly feed of all of the screenings that are in the data lake on the people in the SCNs that each QE is supporting. And we'll also have the ability to query on demand to the data lake. So if a patient shows up in conversation with a CBO or an SCN at noon on Tuesday, they can initiate a query to us to get something that might have been done at 10 a.m. So we will be responding with all the screenings that are done, whether that's the last 3 months, 6 months, 12 months, remains to be determined with the SENs, but it's a big question we're prepared to deliver whatever the SENs want. Next slide, Matt. So I think one of the other major issues that has come up around screening and support of this whole activity is Medicaid has said that the screening tool that they will pay for is the Accountable Healthcare Communities HRSN tool, which has been codified with the Gravity Project's work and has, for the most part, standardized codes, LOINC, ICD-10, SNOMED, assigned to it, which facilitate both data collection, tracking, reporting, and billing for those services. When this process started up, we knew that if we were going to do this with the data lake for the very first time, the Shiny had to really agree up front on all the standards for how we were going to implement this across all 6 of us and in the data lake. The standards on this are emerging. And so we have been working very closely for the last 9 months with folks from the Gravity Project, Civitas, which is the National HIE and Regional Health Improvement Collaborative Organization, who had a grant from Robert Wood Johnson Foundation to help support implementation of these standards in states and regions across the country. That process has been incredibly valuable, both to us and to the Gravity Project folks who work on the standards, because our implementation use case for this waiver is different than a lot of the use cases they had dealt with before of just trying to get the screening data between CBOs and providers and not necessarily aggregate it or report on it in any analytic sort of way to find insights. And so we've spent many months coming to agreement across our network and with Gravity on how we're going to implement it. There will be a New York State Fire IG implementation guide for this that's coming out very soon. And since the state has mandated in the request for applications to the potential SCN networks that they will have to fairly quickly move to bi-directional interoperability using FHIR, we are setting things up with all sorts of tools that we will be able to share with the SCNs to guide that FHIR implementation to meet the standards we're setting statewide. So we're hoping that we can make it as simple and clear for the new SCNs as they come on board as it's possible to be in an evolving standards environment. We've identified a few places where the Gravity domains, which are the areas of social service, housing, food, transportation, education, legal services, et cetera, et cetera. There are 17 of them. Couple of places where we don't think that what's defined so far by Gravity is going to meet New York State's needs for data sharing. One of those is around violence and safety, where the only gravity domain today is around interpersonal family domestic violence, essentially. Losing my politically correct words here. But so if you're getting to that kind of violence, it's in that domain. If you want to know about child abuse, it's in another place. If you want to know about elder abuse, it's in another place. And so we're talking across the state and with the Gravity folks and the Medicaid team about, do we need a couple of New York State specific domains for this waivers purposes? If so, we'll do those in alignment with Gravity, consultation with their terminology and technology leads, and we'll set up local codes to support those that could eventually get linked with Gravity codes if they decide to go in the same direction we're going. So we're trying to be as standards aligned as possible while also making sure we meet the state's needs on this. So the data flow for screenings has been well defined so far. We're actually in testing of bringing in test screenings to all 6 QEs, sending them to NICE for the data lake, testing, getting them back. And then the next step is going to be testing, connecting to some of our existing CBOs or potential SCNs to test, can you take it from us? And how are we going to give it to you? The next stage of that work is going to be around the assessment and referral processes. And all of us are in conversation with at least the 2 major referral management system vendors in New York State, Unite Us and Find Help, who are also already working with many of the potential SCNs. And also, for example, we have one physician behavioral health IPA that's already working with Unite Us, and we have a hospital system that's already working with Find Help. So we've been connecting with them already, as have many of my colleagues across the state at the other QEs. So we're expecting that integration with the referral management systems and the SCNs, that we'll figure that out with them as we know who the SCNs are and what their data systems internally are going to look like. One of the tools that we're also looking at, because while we respect Medicaid's position on only using the HRSN screening tool, at least at the start, we feel that it's important that the data in other screening tool formats somehow gets into the Shiny and can be shared with the SCNs, even if Medicaid may not pay for it as an actual screening tool. So we've looked also not only at that tool, but at Prepare and the other custom screening tools that are in existence in the health systems we work with. We've heard major health systems, New York City, for example, H&H, has said they're not going to change what their screening tool is. So we're expecting that we will have to eventually crosswalk questions, cross different screening tools to the right domains and match them up and code them. And regardless of the payment ramifications of this with what Medicaid decides, we think that all that data has to be brought in and crosswalked and made available in as standard a way as possible. So we're looking at how we, either internally or using some external vendors we know who have great referral information exchange products, that we can take the Find Help and Unite Us and any other referral management system data and map it across the different referral management systems and the different tools. So that's all still quite conceptual, but it's where we're heading with this. So I'll stop there and pass it on.
Great. Thank you so much, Kathy. It has been a pleasure working with you. Kathy and I worked together before the Gravity Project came on board to do that consulting work that Kathy talked about and worked on the original kind of technical requirements document for SDH data exchange. And it's always been a pleasure working with Kathy.
Thank you. Well, just my last comment on this, Matt, is I was going to retire at the end of last year. But when this project came along to try to finally link health and social services, which I've been dealing with throughout my entire career, it was like, I can't leave now. I've got to stay and work on this. So I'm still here.
It's great. We're glad to have you. So I wanted to just highlight a few of the provisions of the Medicaid waiver and special terms and conditions. And I read the 500 pages. There's like 270 of each. Just to draw certain things that might have gotten missed, because there's so much attention on, understandably, on the process of going from assessment to referral to closing the loop in terms of identifying the services delivered and then processing a claim based on that. But amongst the government programs, the government benefits that CMS actually called out in its approval letter, it identified federal and state housing assistance programs, that SNAP, WIC, and TANF, and has identified certain things that the State Department of Health is expected to do. I guess I might have mistyped there, expected, not respected. But in any case, the state's expected to help in assisting beneficiaries in enrollment in these programs. They're expected to track and improve the share of Medicaid beneficiaries in the state that are eligible and enrolled relative to the number of total beneficiaries, and to submit quarterly and annual monitoring reports. And one of the things that really was at the foundation of launching my company was really wanting to see these processes happening via API. We have models from a policy perspective of Medicaid enrollment happening right in the electronic health record. They don't have to go into a separate website and re-enter information, but that we could do the same things for these other programs by enabling entities to send this, whether it be a SNAP document or WIC information or TANF, directly from whatever system they're using. With the actual data that needs to go into the form. So I just wanted to draw that out. These are provisions that are oftentimes overlooked. Zach, do you want to introduce Public Health Solutions?
Sure. And I hope I can bring some human focus of the experience of Medicaid members and community members themselves into the conversation, because our organization's mission is supporting New Yorkers to achieve optimal health and build pathways to reach their potential. Our vision is healthy families, thriving communities, and health equity in New York City. And we operate sort of on multiple levels to achieve our goal of health equity in New York. We provide services in local communities in over a dozen languages across the 5 boroughs that improve health and economic well-being. We're the largest provider of WIC in New York State. We help people enroll in SNAP and health insurance benefits. We provide many maternal and child health services, as well as operate sort of a coordinated intake for maternal and child health services. We provide free sexual and reproductive health care in some of the highest need communities. So we know and have the experience of doing community work for decades in New York City and what it takes to do it well. We also are an administrative backbone for the city of New York, supporting our government and healthcare partners administer contracts and payments efficiently and effectively, getting those resources to where they're most needed and ensuring contracts that work for community-based organizations, and especially small community-based organizations. This grows out of our experience since the 90s with Ryan White. And if you think about Ryan White, if you're familiar, Ryan White formed to provide services that address the social drivers of health, which weren't even referred to back then, but they were the support services that people needed who were living with HIV that were not going to be covered by Medicaid. And so many years of community partnering with community and community-based organizations to define and prioritize what those services were, how to make them effective, and how to effectively administer them is where we're coming from. And then our healthcare community partnerships over the past 5 years, where we've really been developing coordinated and accountable networks, trustworthy. I've left that word out of the slide, but I wish I hadn't. That bridge health and human services to make sustainable impact in community health. You will not see the term social care on my slide, and I will do my best not to say social care networks, even though it's on the tip of everyone's tongue, because humans don't understand what that means. What if I came to you and said, I'm here to assess your health-related social needs today? No. We need to talk to people we need to meet people where, when, and at the right time to talk to them about their economic circumstances. How are you doing putting food on the table? How are you doing with your rent? Are you having trouble with your housing? But in the right place, in the right way, from the right messenger, at the right time. And so, that's really what we're all about. And I just want to say that when it comes to the social care networks, I love that this panel was called Leveraging the Medicaid Waiver, because we believe that this is just one of many potential critical investments in what is currently a missing piece of the public health infrastructure. Imagine a world where accessing community resources was modernized the way we access an Uber, the way we access food via Seamless. This is just the beginning of investment in that infrastructure. But with the right people leading social care networks in partnership with government, we can begin to put the building blocks in place for a modern future of how people access resources. So very excited to be here and hope we can really keep top of mind the experiences of community members when we think about what it is that we're building here and how.
Thank you so much, Zach. I just wanted to emphasize and underline how we talk to people is so important, and how that there's sometimes a challenge and that standards comes at things from the opposite direction of standardizing something, and can get in the way of using language that actually reaches people sometimes. So I just wanted to underline that, and that is a very good point. Pam, do you want to introduce your organization?
I do, thank you. And actually, I would like to also just note how appropriate it is that public health, and I'm going back to you, Zach, a little bit before I launch into CBC, but it, I think, is really important part of this conversation, how public health is overtly now part of the healthcare transformation in New York State. We have long talked in the field of healthcare about our silos. And so I think there has been, of course, a lot of focus on primary care and hospital-centric care. There's been growing recognition of behavioral health and now social care needs. And I think it's just really to the credit of HIMSS to include public health as a really credible partner in this healthcare transformation. I have long worked with Public Health Solutions, so full transparency, I really admire the work that's done there. CBC, yeah, I have here on the slide, CBC Enterprise, because as an organization, we are called Coordinated Behavioral Care, but our clinically integrated network of over 77 non-for-profits serve about 150,000 people every year throughout the network. And the enterprise consists of our independent practice association, our health home that you mentioned a little bit earlier, and some other collaborative programs that are part of our IPA. A real value that the enterprise rests on is this idea about collaboration. And I'll probably end up talking a little bit more later about the importance of rethinking collaboration from sort of the standards that we've developed over time to really thinking about it as radical collaboration, where we are pushing intensely at working differently with each other in service of the people that we're all dedicated to. And I'm sure that Mark will have a lot to say about radical collaboration as well. Just at a high level, our network has programs throughout New York City, Long Island, and Lower Westchester. And much like what Zach said, we are incredibly committed to developing and working on solutions with the broader healthcare system. It's not on this slide here, but not just the healthcare system, but I would say non-traditional stakeholders. We do a lot of work, for example, with the MTA and the police and other parts of our system that make up the sort of the ecosystem for where people live. We have a great relationship with our payers, of course, government, and hopefully part of the promise of this waiver is to have increasing community engagement. So you see in the bullets, those are representative of the services that the entire network provides. And I will say, not traditionally thought of in behavioral health that social care needs would be provided, but we did do a survey of our members and found that there are hundreds of programs that social care needs are already being provided. And so again, a great opportunity for all of us to come together and, as you pointed out, leverage the resources we already have to work stronger together.
Thanks so much, Pam. Mark, can you introduce Care Compass, please?
Yeah, Matt, happy to do so, and just want to thank the panelists and HIMSS for putting this together. I'm so encouraged by hearing everyone's overviews and their missions and how they're all approaching the same populations that we're all trying to work with. It's refreshing to hear about so much innovation and hard work that's going on across the state. If you've not heard of Care Compass Network, I'll try to give a little bit of a snapshot. We're a newer organization that was formed in the southern tier of New York State. We're headquartered in Binghamton, New York, around the original 1115 waiver that we now call DSRIP 1.0. And throughout the course of DSRIP, just to have a scale of the sort of populations that we worked with, in any given year, we served upwards of 125,000 Medicaid members in a given year. And Care Compass Network, in the work of DSRIP and the work that we've done post-DSRIP, we are a collaborator and a convener. We don't provide services direct to Medicaid members, but we help coordinate those services for them. So as you look at serving 125,000 Medicaid members, no staff of Care Compass Network delivered those services, but that was all from the organized, and I like radical collaboration, Pamela, from across the community. I'm going to have to use that one from now on. But a little known fact, you may not have heard any of the press on it. The state was pushing out hundreds of pages of DSRIP report cards and different things. But the southern tier in the DSRIP program was a really, really high performer. In year 4, the state did certain demonstration years. In DY4, we were the top performer with regards to our baseline metrics and how many of them had improved or were trending towards improvement in the year 4 measure. And again, that's not a status of CareCompass Network, a singular organization. That's a representation of a collaborative of hundreds of organizations from across the Southern Tier trying to support and improve quality of care and improving costs for the Medicaid population. So we're really excited to see that and have continued to push that envelope. Since DSRIP ended, we still work with over 130 different organizations today. And we're really specifically trying to drive the advancement of Medicaid VBP. And with that comes a lot of things. It's not just education, but it's readiness for CBOs. It's finding creative ways to help CBOs collaborate in a meaningful way that's valuable to VBP contractors. You can see here, one thing that we noticed very early on was that from a health equity perspective, some organizations had health equity campaigns and ways of organizing internally, or even health equity strategies, and others didn't. But there wasn't anything regionally that was trying to say, hey, as a region, what are themes? As a region, what are things that we can see? So we did organize a health equity council in 2022, and they've been able to help inform different initiatives that have been going on across the region. And I'll just give a plug for 2 different types of innovation that we've been doing these past few years. One is called a social impact pilot program, where we help to organize CBO networks to support existing VBP contracts. And so we go to health systems, FQHCs, different VBP contractors and say, where in your Medicaid contracts are you not able to hit current metrics and measures? And how can maybe a collaborative CBO health system aligned strategy help address some of those needs? And so that's been a real creative way to try to address some of the needs of the community, and also brings up some very big technical challenges. How do you approach data sharing? How do you approach all the things that functionally make that sort of an interaction work? And a latest one, we have so many acronyms here, but STITCH, the Southern Tier Integrated Collaborative Hub, is an effort where we said, okay, it's helpful to tackle behavioral health and SUD issues within the confines of a singular contract or a singular county, let's say, but we have to start looking at this on a broader scale. We have to start looking at this on a regional basis. So we've been working to find how can we better coordinate and create new services for this population across what we work in, which is a 9-county region of the Southern Tier. So we're trying to bring in enhanced telepsych, mobile response teams, and even find better ways to intentionally collaborate the clinical and social care providers to the betterment of that population. So a lot of innovation still underway, upstate New York, and I'm happy to, I guess, hand back to Matt, I think, as we go into panel discussions.
Yeah. I will just take one slide to introduce Open City Labs. So we offer a configurable clinical and social care plans. It's our Navigator 360 product, and that leverages AI to present a 360-degree view of the patient and family house. It looks like households is cut off by the image there. That includes assessments, closed-loop referrals, and we're able to essentially autofill forms. So, autofilling a form to refer to WIC or SNAP. We have a patient or caregiver-facing app, Care 360, and then our social health information exchange, G360, is this AI-driven infrastructure, which includes a directory that includes not just the healthcare and social care organizations, but also 256 New York State and New York City-based government programs and 63 forms like the SNAP and WIC forms. We've conducted a randomized controls trial that showed our software reduced the likelihood of a SNAP application from being denied, nearly cutting it in half. Yeah, and I'm going to just kick off the conversation. So recently there was a report that came out about that New York City saw one of the largest year-over-year increases. So, but first of all, before I just wanted to do a time check. I know we only have about 14 minutes left officially in the event. We're going to just extend it. If you need to leave, feel free to drop. But we're just going to stay on for an additional 10 minutes so we can get into more questions. So I'm going to start, direct the first question to Zach. So, and a lot of people are very familiar with the numbers on kind of a high level. This report, this poverty tracker report, saw the largest year-over-year increase in poverty in New York City, increasing from 18% to 23% in 2022. That includes 56% of New Yorkers, more than 1 million children, live below 200% of the poverty level and struggle to make, and the child poverty rate jumped by 66%. So I don't know how do you want to talk about some of the challenges that you see Medicaid patients facing in your area, what they're experiencing, and how you vision the upcoming waiver could begin to address these issues? Zach, why don't you start?
This news was no surprise to us. We had been watching our numbers rise and rise and rise when it came to cash assistance applications requests, SNAP, WIC. We all know about the rising food costs. WIC just becomes more and more valuable. So when this came out, we were not at all surprised. What does this mean for the social care network? Well, it means it's more important than ever that we begin to chip away at the wrong pocket problem and make sure as many of these resources as possible go towards the actual provision of community-based services that address people's economic circumstances and not further expand the healthcare enterprise, which is costly and not equipped or experienced in providing many of these services and supports. The state has the right idea here by prioritizing community-based organizations and those particularly that have small budgets that are culturally and linguistically specific. Because we see this in our local community service hub sites and in our whole UNYC network data. We're talking about Corona, Queens. We're talking about East Tremont in the Bronx. We're talking about East Harlem. We're talking about neighborhoods in South Brooklyn and Central Brooklyn, Bushwick. So what I think is really important for a social care network in thinking about how does it address poverty, but also in how does it become sustainable, is the opportunity here to develop infrastructure that meets the needs of Medicaid members as described and interoperates well with healthcare so that there's seamless transition across those sectors, but is not so rigid that it cannot take on other use cases for the aging, for the social services, and that over this course of the 3 to 5 year demonstration period, these social care networks begin to partner effectively with government and be used as a tool to support government in braiding funding to be more effective and efficient at reaching people and integrating with the existing social safety net infrastructure. So we have been bringing in through our symposium series over the past, since 2020, to talk about this infrastructure, local government entities, to ensure that they have been planning and thinking about how they might benefit from the social care network construct.
Great. Thanks so much for that, Zach. Mark, can you talk about these challenges in upstate New York? I wanted to really make sure that we had the balance of the kind of the views from areas where are more rural and then areas that are more urban. So could you talk about some of the challenges and how you think the waiver could impact these issues?
Yeah, Matt, you know, I preparing for this, I spoke with a few people because I had my own ideas, but I wanted to get the input from a few folks locally just to fact check it. And everybody immediately first said it's all about access, and that includes availability as well as capacity. So as you get into you know, the upstate region, services are not uniformly available. And what's really good about this waiver is it has meaningful ways that it seeks to address that. The waiver specifically requires that the social care networks will identify regional service gaps and have plans of how they're going to improve on that. There's infrastructure funds that are available that they could use to help target some of these gaps. That might include the ability to scale up existing services, but also we're having lots of conversations about where some infrastructure funding recommendations might be made to create services where gaps exist. And nobody really has the money to do this. So the waiver really has certainly opened up creative thinking where you know, the regions might be thinking, oh, wow, how are we going to overcome this big barrier? Another one is by virtue of introducing the social care navigators, the waiver also you know, very directly positions the Medicaid members to be able to maybe point it in the way of services that they just didn't know that it existed, let alone some of the new ones that are being created.
Great. So I wanted to invite people to put their name and role and organization in the chat, and feel free to ask questions, and we'll do our best to respond to them in the chat. So I wanted to turn to Pamela. So given that you run one of the largest Medicaid health loan programs, how do you envision the eligibility, enrollment, coordination of services kind of happening together? One of the things that has jumped out again and again in the CMS waiver is don't spend, you cannot reuse money from this to double compensate that. So how are these things going to play along with one another? How are they actually going to be integrated?
That's a great question, Matt. That's a great question. Let me take a step back for a second. So I think everybody knows that care management is really a response to a very fragmented and siloed healthcare system, right? It's our sort of solution to help the consumer navigate and have greater access and coordinate services. What has happened was a really good intent. I obviously really believe in it, given the focus of us being a lead health home in New York City. What has happened is care management has become its own profession. And every organization, every program has care managers. You can call them case managers or care managers, but everybody has one. And if I go back to where this whole waiver is to improve health and well-being for individuals and families, if we just remember for a moment that any one of our members could have 5 to 15 care managers. You can have one in your FQHC, in your Article 31, in your health home, your probation officer, et cetera, et cetera. And so what the hope I would have liked to seen as a health home in this is really what is the central opportunity to leverage health home to organize the care management across the system. So while I really love the idea of a social care network, the other side of that coin is it's another siloed system that is going to have to work at integration. It isn't immediately part of the fabric. And so we're going to have to work harder again for that type of collaboration. Why I also spend a lot of time talking about this is if we had a sort of unified care management approach, we would increase accountability, decrease duplication, certainly improve client experience. I would know who to talk to, and then there's sort of a group of people with different expertise that would access things for me. And it would also, I think, be a big cost savings to the healthcare system at large. So probably I could say a lot more. I get it. I'm on my soapbox.
Can I piggyback on Pam?
Sure. If we don't mind, just to all of you, like if we can keep our responses to like 2 minutes at the max, so we can get to more questions. And I want to get my next questions for Kathy. So, but go ahead, Zach.
I'll be very brief and just say that I think one of the important objectives of the social care networks should be only to serve as a navigator of last resort, so that to the greatest extent possible, we are employing what Pam described, kind of leveraging existing or a unified care management approach, and reserving, what the state has described as the social care navigation workforce for those situations where someone has truly slipped through the cracks in the system of the social care network and nobody has been made responsible for their navigation or case management. So I think that's an important attribute of a social care network.
So this next one is for Kathy, and Pamela really set you up for this one. Given the risks of a social, like this waiver kind of creating its own silos, I wrote a blog post, I'll put in the chat, that is really trying to say, what if we envisioned the Medicaid waiver as kind of kicking off interoperability across all state agencies, right? What if that was just the first part of a blended funding stream, so that we're interoperable with OCFS, we're interoperable with aging? No, my question is, first of all, how do we avoid those silos? And secondly, when you were in those standards meetings talking about the interpersonal violence, you had the aging violence, which is regulated not by DOH, but by AID, the Department for the Aging. And then OCFS is going to be the child. So were those people at the table, and how do we avoid the silos?
They were not at the table with us. They may have been at the table with Medicaid, but because of all the confidentiality rules around the development of the waiver, we weren't in those conversations with everybody. However, our colleagues at the State Department of Health has shared a vision with us that does include working to get data into the shiny data lake to be shared and used across the network of all the members of all the QEs, including the SCNs and local health departments as well, who are key to some of the gaps in these networks we're talking about, particularly for the uninsured. That there is a vision that we will have data from other DHS, New York State Department of Health operated programs. So OCFS could be in there, WIC and the food programs could be in there. We are lobbying strongly for expanding that to other state agencies and their local agency counterparts like OMH, the Office of Mental Health, OASAS. We have a huge project going on with us and HealthX and OMH now to be giving them bulk data that they need to assess the high ED utilizer population and the relationship to homelessness there. We want the DSS and DHS data for the housing and homeless issues. We are pushing really hard on all of them. There is some new regulation out for public comment right now, came out on the 14th, that will hopefully support the ability to get a lot of that Medicaid and Medicaid related data into the Shiny, because there have been some regulatory roadblocks to that. But I think we need the entire community advocating for bringing all of that data together. There are other states that have started to work on what they call a health data utility concept, where all of the relevant data, health, social services, education, criminal justice, all can get integrated in one data system that's properly secured and access controlled and consent regulated, et cetera, but where everything is accessible together for the folks who really need to know all aspects of that personal elephant that each of us has. So my pitch would be, let's work together to advocate for that.
Great, thanks. I'm gonna turn the questions first to Mark, but if we can lightning round this so we can get to each of the speakers about this. Mark, what is your biggest technology pet peeve? We probably have a lot of technology people in the audience here at HIMSS.
Well, just to be short, technology is not the mission. You know, it's a big enabler. And what I find challenging about this work is technology milestones are very easy to monitor in a way and get excited over. We've got 100 organizations connected to a system, or we've achieved XYZ milestone of interoperability. But we've always got to keep our lens on how is quality doing? Are we improving costs? You know, how efficient are we being at the work that we're doing? So to lightning round it, I'd say to keep the ground level workflows at the front end.
And I want to be clear, the reason that question is the second to last question is because I even though I run a technology company, I agree that technology is not the mission, and that technology and standards need to be downstream from the workflows that you're talking about and from the needs of the community and from et cetera. I have a blog post about that, shameless plug for my newsletter. Pamela, biggest technology pet peeve, lightning round.
That it has not solved for the problem of administrative burden and time spent at the computer instead of with the client.
That is exactly what Open City Labs tries to solve for. One of the ways that I sometimes talk about technology on a philosophical level is I say the best technology is like light. We can sit here and have a conversation and connect as human people we don't have to think about light, right? It just enables us, right? So that's one way I think about technology. Zach, the biggest pet peeve.
It can be dehumanizing and treat people like they are widgets in a machine. And you can remember when doctors used to sit face to face with you, and that they can detract from the human connection that is so vital for behavior change and for making a difference in people's lives.
Great. So I have one last technology question because we're already 5 minutes past time, and so obviously AI, the conversation about AI is in the zeitgeist, right? I want to just set this conversation up a little bit. Imagine you're a professor, or let's say you're bringing on a new someone who just graduated from college, and you learn because you knew their professor that this person could memorize all of War and Peace and then analyze it and spout back little sections of War and Peace and give a full analysis of it. And then he's working with you and one day and he makes a mistake, right? So I think it's important to think about, first of all, obviously there's a ton of importance in AI safety and alignment and security and privacy. And so I think those are the things that are important. But I just want to make sure that also that when you have some technologies that are, that powerful, that are almost genius human level, that we're not kind of throwing the baby out with the bathwater, right? So I just wanted to maybe we can start with you, Zach. What is your thought? What are your thoughts about AI and potential role? I mean, that could be potentially play some of the role in restoring the humanity of, being people, or are you skeptical? I don't know.
There is a lot of indication that our data is racist, which means that AI will learn our biases. And I'm very concerned about that. I'm very concerned about AI being used to identify people who are at risk or who have social needs, because basically it's going to be based on a racist data sets. So that's my biggest fear about it.
Okay, Pamela,
I would jump in and echo that. Sure. Completely. And we are using some machine learning tools and techniques for our risk stratification models, high ED use, but we're trying to be very careful and aware of how we interpret that. It's going against our own data, not anybody else's. So we're hoping that because of the composition of our population, we may avoid some of those pitfalls, but we're very, very cautious about that issue. I 1000% agree with what Zach said.
Pamela, do you want to go next?
I would just say, of course, I thoroughly agree with Zach and Kathy on the key issue about computers particularly spit out what we give them. And from our mental models. I would also say on the other side that I think there's enormous potential for AI to be an important consultant to us so that we're able to use that information without having to spend a lot of time researching for the information and then put it into our human-centered thinking.
Mark, what about you?
I think there's a lot of power and potential, but as the groups pointed out, you have to be able to, have it be productive and producing things in a thoughtful way. So hopefully we can find a meaningful way to engage it. And I think the group's got a good number of ways of exploring different ways to maybe capitalize on it. I'm sure the conversation on this would be, drastically different 1 or 2 years from now.
Okay, I'm going to take the speaker's privilege and just close out the conversation about the AI and how it's used in our tools. So because people kind of tend to think about it all being one thing when there's very, very different usages of it. There's an old saying, it's like that as soon as it works well, we don't call it AI. In other words, AI is embedded in just about like products everywhere from but the way we think about AI at Open City Labs is first, if you have a provider looking for information across a record, having a powerful search that allows them to access the information from that record, right? That can get them the information they need to deliver care, can deliver better care because they have the information. They don't have to go searching through 1,000 notes, right? That's one area. Second area, if there was a three-sided coin, I would think about interoperability, standards, and AI as three sides of that coin. Standards is a process of the community coming together and agreeing on how are we going to represent this thing, this concept of food insecurity. What questions do we ask to get to the determination that someone is food insecure? And AI's or machine learning's approach of looking at unstructured text and saying, what does this thing mean? What does this sentence mean? Is this sentence the same sentence as this other sentence over here? So you can apply AI ML to enable interoperability, to advance with humans in the loop, making sure that data mapping has been done accurately. And once you've done the mapping before, you can, and it's been verified, you can then reuse it again and again and again next time you see that. So anyways, those are some of the ways that OpenCity Labs does it to streamline the access to these workflows by making sure we have a person in the loop. The mapping has already been done between the SNAP application or the WIC application and the standards, and we can leverage this rich data with the person's consent to streamline service enrollment so that people can, individually, that services are individually personalized, universally accessible, and one click away. Well, we held you 11 minutes past the time. I apologize to anybody. Thank you so much to the panelists. We've had a really brilliant conversation. I'm really grateful for the knowledge and expertise you've brought. Anthony, do you want to close us out, or?
Sure, we'd love to. I would like to say thank you to all of our presenters today. Great job. The information that you shared with our committee was fantastic. And if anybody is interested or going to be down in Orlando, we have a luncheon that's scheduled on the Tuesday, March 12th from 11 to 1. Please come and join us, and you'll be able to meet some other exciting members of our chapter. And also look to come and enroll, become part of our chapter. Matt, thank you very much. Along with the rest of Catherine, Zachary, Pamela, and Mark, great job. And also Elise for helping to put this all together.
So the last thing, if the panelists have if they feel they can or they want to, we can put emails in the chat if organizations are interested in reaching out to talk about potential partnerships. Since we didn't get to so I'm just going to put my email in there.
Great.
And thank you.
And by the way, this is recorded. It'll be on our YouTube page, available probably look for about 24 hours after.